people understand what I'm trying to talk about, and they don't look at me like I'm from a different planet.
I can assure you, if I understand it, anyone will.
Good. So, John, I think we're done with the evaluations.
I know it's somewhat of a miracle, and I really appreciate your help. Wow, together, I think we got everybody.
Yes, we did.
I found 4 people last night that had done them, but didn't show up in the computer. So I had them send me screenshots of what they did.
Good.
Yeah, this should be a great presentation today.
I'm gonna get ready to share here my slides and get ready to present.
Looks good.
Okay, thanks.
I think you should have a bigger picture of yourself, Jose. Leading the way and the vanguard of pulmonary medicine.
I wish I could show people the channel site, but they'll have to see my boring office.
Yeah, it's hard to capture some of the passion in a lab sometimes. You show a picture and it looks so dry and stuff. You need to have people running around doing stuff.
Exactly.
Recruit a dozen medical students to run around, take a quick picture, and then close out.
Yeah, but this is, I have a beautiful view from channel side from here.
Yeah, you deserve it. That's good.
Well, you need the view to do the science, right? Because like you said, when you go to the lab, it doesn't look as nice.
Well, I'd use the argument that it improves your vision of the future.
That's right.
Now, how does this fit in with the Center for Advanced Lung Disease? Should I bring that up or just stick with
You can. You certainly can. Actually, I had the Center for Advanced Lung Disease down there in my titles and some others, but I just took them off because I didn't want to, But yeah, I mean, that's where I practice. That's my clinical practice, right? So pulmonary fibrosis. So essentially, the Oven Center is the basic research arm of the Center for Advanced Lung Disease.
Okay.
Basic and translational research arm.
What a smart way to do it.
Yeah, I mean, I think that, if any clinical center has their, basic and translational research lab, I think that's right, because essentially this is where we develop new drugs and, we have clinical research people to implement them and the doctors taking care of the patients, right? So that's the triangle of academic medicine.
The virtuous triangle, they call it.
That's right.
Yeah, that's, I think that actually leads to the most satisfaction in the division, where you clarify a problem, create new knowledge, and apply it to the patients.
Correct. Yeah. From the bench to the bedside.
Exactly.
We've got good attendance if you want to get started.
Okay. This is John Sennett. It's my honor, truly my honor, to introduce a close friend and brilliant scientist, a great leader, Dr. Herazo-Maya. Dr. Herazo-Maya had an elegant training in pulmonary and critical care medicine, but more importantly, he himself has an immensely creative mind and the ability to implement his creativity. He is the Oven Endowed Chair. He directs pulmonary critical care and sleep medicine. Also, he's the primary research arm for the Center for Advanced Lung Disease for basic and translational medicine. It's my honor to introduce him today, and I'm really excited to learn more about this topic. Go to it, Jose. Thank you.
So let's start by an outline of my talk. So first, we're going to talk about idiopathic pulmonary fibrosis, definition and pathogenesis. IPF is the disease that I focus on in my research. So we'll touch on diagnosis and treatment of IPF, on the clinical course of IPF, and what I call the dawn of personalized medicine in IPF. And as the talk goes on, we're going to move from clinical to translational to basic science research, so please bear with me. After talking about the dawn of personalized medicine, we'll talk about genomic risk profiles in peripheral blood in IPF and COVID-19, and particularly a gene that I'm very interested. It's called mast cell expressed membrane protein 1, in the role of this gene in pulmonary fibrosis pathogenesis, and we'll finish with a summary on future directions. So what is IPF? So IPF is defined as a specific form of chronic progressive fibrosing interstitial lung disease of unknown cause. That's why it's called idiopathic. It happens primarily in older adults in the 5th or 6th decade of their life. There's a 2-to-1 predominance ratio of females. So males get more affected than females. And it's limited to the lung, which is very interesting. Symptoms include mostly dry cough and dyspnea. And on exam, you can hear dry, basilar, Velcro-like crackles, which distinguish them from heart failure. And, this patient is a very terrible disease. The median survival is, is about 3.5 years, with a range of 3 to 5. To be able to call a patient IPF, you have to exclude other forms of idiopathic interstitial pneumonias and ILDs. And this patient should not have had a significant history of environmental exposure, medication, or a systemic disease. So this is what the CT scan of patients with IPF look like. So the disease spared the apices of the lungs. And as you can start seeing the scan in figure B, you start seeing peripheral-based reticulations with something called honeycombing. If you look at the figure E, you will see how this honeycomb cyst starting to appear. And there's another feature that you cannot see really well here. It's called traction bronchiectasis. You can see this in figure B. So peripheral-based, lower lobe predominance, traction bronchiectasis, and honeycombing are the main radiological features of IPF. On pathology, you see something called temporal heterogeneity. What that means is you have healthy lung tissue adjacent to scar tissue. So this is the normal, with the arrow, this is normal lung tissue, and adjacent to it is this thick band of a scar. And if you look at high power field, you'll see this hallmark of IPF called the subepithelial fibroblastic foci. So, this is essentially what defines idiopathic pulmonary fibrosis. What causes IPF? Well, this is actually a slide because, there's multiple hypotheses, right? But this is one that actually adjusts to my view or my hypothesis of the disease. So there's two processes in the healthy alveolus. There's alveolar epithelial cell injury, and there's normal repair, and there's disorder aberrant repair. So IPF is thought to be caused by repeated injuries of the alveolar epithelial cells, and when these cells get damaged, that leads to monocyte recruitment, transition to macrophages, and these macrophages turn into profibrotic macrophages that lead to the recruitment of fibroblasts, and this fibroblasts lead to scar formation. So there's there's also a significant genetic association with idiopathic pulmonary fibrosis with polymorphisms identifying the MOC5B gene, which is a mucin gene that seems to predispose patients to alveolar epithelial cell injury. This slide is to just show you what the HRCT patterns or high resolution CT scan patterns are in IPF. So one is the UIP pattern, or usual interstitial pneumonia, which is the hallmark of IPF. So this is the definitive UIP pattern, and you can make a diagnosis of IPF confidently more than 90% of the time. The probable UIP pattern, you can make a confidence 70 to 89% of the cases. In some of this probable UIP patterns, you may have something like ground glass opacities, for example, or you may have a little bit of upper lobe disease. Then there's the indeterminate pattern for UIP, which gives you a confidence of 50 to 70%, where you could have, for example, more diffuse distribution and other features that suggest alternative diseases, right? And finally, the alternative diagnosis, which gives you a low to very low confidence, less than 50%. And these are the CT scans that we normally see in patients with non-specific interstitial pneumonia, or when you find cysts, mosaic attenuation, predominant ground glass opacities, micronodules, et cetera, et cetera. This slide is just to show you that how we tend to correlate the pathological findings with the HRCT findings. So if we have a UIP HRCT finding plus a histological pattern of UIP, we tend to call this, or we call this IPF right away. If we have a probable UIP pattern and a definitive UIP pattern, we call it IPF. So essentially what defines your diagnosis is your pathology. Now, if your pathology suggests an alternative diagnosis, it doesn't matter how your CT scan looks like, you wouldn't call this patient an IPF. This is sort of the diagnostic algorithm. So after you suspect someone having the disease, you obtain an HRCT pattern. You determine whether it's a UIP or probable UIP, and then, or an indeterminate for UIP or alternative diagnosis. So if you have a UIP pattern, you take this patient to a multidisciplinary discussion meeting, what we have every Friday at the Center for Advanced Lung Disease. Dr. Patel, myself, Dr. Bandy, we sit down with the radiologist and the pathologist and discuss cases. And if we think that this patient fits criteria for IPF, we call it IPF. If we don't think the patient meets criteria for IPF, then we either take him for BAL with cryobiopsy, transbronchial cryobiopsy, or a lung biopsy. And then we take this case back to multidisciplinary discussion meeting on Fridays. And then we decide, okay, is it IPF or is it an alternative diagnosis? So this is how we make the diagnosis. So let's touch on treatment here. So there's some treatment considerations. So pharmacological, nintedanib and pirfenidone are the only two drugs approved to treat pulmonary fibrosis. They do not improve survival. They slow the progression of the disease. There are other non-pharmacological considerations. For example, all these patients, if they are hypoxemic, they should have oxygen supplementation, pulmonary rehabilitation. We should be looking for comorbidities and treat those comorbidities, for example, pulmonary hypertension. So in our center, we have Dr. Restrepo, who we often send our patients to him. So there are drugs right now that can be used for treating pulmonary hypertension and in pulmonary fibrosis. For example, one that is commonly used is inhaled treprostinil or Tyvaso. And others comorbidities, so GERD, so often we send our patients to Dr. DuCoin for Nissen fundoplication, or Dr. Anderson for evaluation and management of sleep apnea, and so forth. So these patients often develop lung cancer because the fibrotic lung, it's the perfect tissue for lung cancer to grow. So it's very important for us to follow those lung nodules. And it's very important for us to also monitor disease progression. So we follow them every 6 months. We look at lung function over time. And if we see any evidence of lung function decline, we tend to take these patients and send them to pre-transplant clinic to Dr. Patel so that he can assess whether the patient is a good candidate for lung transplantation or not. Acute exacerbations, we'll talk a little bit about them. We treat them with corticosteroids, although there's no great evidence to suggest that that really works. And, palliative care sometimes is an option for some of these patients. So nintedanib, as I mentioned, is one of the drugs used to treat pulmonary fibrosis. It's a triple kinase inhibitor that blocks vascular endothelial growth factor, platelet-derived growth factor, fibroblast growth factor, has some anti-angiogenic and anti-tumor activity. And the Impulses trial published in 2014 in the New England Journal of Medicine by Rick Keldy and collaborators show that patients with taking nintedanib 150 milligrams twice daily had a lower rate of decline. So in this graph in panel A on the y-axis is the adjusted annual rate of change in forced vital capacity. And if you can see, patients with nintedanib decline about 114 milliliters, and instead of patients with placebo, for example, who decline about 240 cc's per year. And so they did this validation study called Impulses 2, and they found exactly the same thing. Patients taking nintedanib had lower rates of progression compared to patients taking placebo. And the same year, interestingly, they published on pirfenidone. So pirfenidone has a lot of pleiotropic effects, acts in the Wnt beta-catenin pathway, transforming growth factor, matrix metalloproteinase and collagenase and reactive oxygen species. But several models of fibrosis, especially in bleo model, pirfenidone seems to decrease the amount of fibrosis. So in this trial, Ascend, they actually show that they use a composite outcome, which was decreased forced vital capacity or death. So patients taking pirfenidone had, decreased, had slower progression of the disease and improved survival compared to the patients taking placebo. So in figure B, you can see on the y-axis the mean change in forced vital capacity milliliters. So you can see the patients with placebo actually decline faster than the patients taking pirfenidone. And I thought that it was important for me to show you guys the study because this is called the Panther trial, which showed that immunosuppression, which is what we used to use in the past to treat these patients, actually increased the risk of death and hospitalizations in patients with IPF. So essentially, immunosuppression for IPF doesn't really work. So, and this is really what drove my interest for research. It's the variable clinical course of IPF, which is highly unpredictable. So for some of us who see these patients, you'll notice that some patients actually, by the time they present to you, they decline very quickly and they die within a year of diagnosis. Some other patients can live with stable disease for 6 years or even more. And there's this pattern of patients that have this so-called acute exacerbations when they have, lots of ground glass opacities in their CAT scan. We call it alveolitis. And then their lung function declines significantly. They stabilize until they have another exacerbation and then they die. It's kind of like ARDS or acute respiratory distress syndrome and a background of lung fibrosis. So why is outcome prediction important in IPF? Well, because we can, if we know who's deteriorating, we can refer them early for lung transplantation. You can stratify these patients into subgroups for drug studies. You can consult palliative care early, and patients sometimes want to know. They want a question they ask you is, am I going to die? So that's why outcome prediction is very, very important. And that drove my research interest, and I published this article 10 years ago today. It was a review article, and it's interesting how the residents that were with me at the time say, "Are you still studying this kind of boring disease?" And I go, "Yeah." So what is personalized medicine? So personalized medicine or precision medicine focuses on the individual molecular and omic, so genomic, epigenomic, or proteomic information to direct more efficient and cost-effective strategies to prevention, diagnosis, outcome prediction, and treatment of diseases. So, you know, and I talk about this, the validation and implementation of such approaches will be crucial to personalize IPF patient care, prioritize lung transplant, and stratify patients for drug studies, as well as in the future, 10 years later, predict response to therapy as they emerge. This was 10 years ago. So at the time, we used something called microarrays. So the technology has evolved dramatically. Now we use RNA sequencing and single cell RNA sequencing. We're going to talk about that. But microarrays were essentially slides. And what I would do is I would take blood from patients, extract cells, lyse the cells with a substance called trisol, and then cook that liquid with the slides overnight. And this slide had DNA probes bound to the slide, and we can actually estimate or detect the presence or the RNA transcripts of the entire human genome. So we did that experiment for a cohort of patients evaluated at the University of Chicago and validated the results in a cohort of patients at the University of Pittsburgh. This was when I was doing my residency. So at the University of Chicago, we found the signature of 52 genes out of the entire human genome. 52 genes were predictive of survival in IPF. 7 of these genes were increased and 45 of these genes were decreased. Yellow means the genes are high and purple means the genes are low. So, and this is important. Remember, yellow is high, purple is low. So this was the discovery cohort at Chicago, and then the validation cohort, we use artificial intelligence. It's interesting because now everyone talked about artificial intelligence. We were using artificial intelligence, you know, a decade ago. So this is machine learning or hierarchical clustering. So we give the computer a set of genes and numbers, and then the computer tries to put together the patients with a profile apart from the others. So as you can see, this cluster 2 patients had increased expression of this gene and decreased expressions of this 45 genes. And cluster 2 patients had increased risk of mortality. So this is a Kaplan-Meier plot. Y-axis is the survival probability. The x-axis is the time in years. So the median survival of patients in cluster 2 was about 1.7 years, whereas the median survival of patients in cluster 1 was about close to 3.5 years. So these patients die faster. You know, we study a small patient population, so we couldn't really detect any clinical differences between the 2 cluster of patients except for transplant-free survival. And when we did pathway analysis, we discovered that a lot of the downregulated genes were enriched for this pathway called the T-cell co-stimulation pathway. So this pathway includes genes such as CD28, LCK, ITK, and ICOS. So the patients who tend to die faster had possessed some sort of an immunodeficiency. We could explain why they actually did worse when they were given immunosuppressive therapy. So we actually validated these genes using qPCR. So again, these are Kaplan-Meier plots, and we show by qPCR that patients in the Pittsburgh cohort with low CD28, ICOS, ITK, and LCK had decreased survival compared to patients with high level of these 4 genes. We then correlated using PCR and found significant correlations of these genes with the percentage of CD4 positive, CD28 positive cells. So again, demonstrated that patients with IPF with progression had low numbers of CD4, CD28 T cells and decreased T cell costimulatory genes. We also wanted to know whether we could use genomic information to try to improve outcome prediction in IPF. And, you know, we combine, we use clinical, so age, gender, and forced vital capacity, and combined with the gene expression of those 4 genes. And we created this genomic and clinical prediction model. This is an AUC. So as you know, an AUC higher than 0.7 it's considered acceptable. But our AUC got close to 80% when we combined genomic and clinical information compared to genomic alone or clinical alone. and this was statistically significant. So, so then the next question is, can we validate this 52 gene signature in other cohorts, and do these genes change over time and with disease progression? So to answer the first question, we designed this very large study when we took patients from multiple academic centers, Yale, London, University of Chicago, Pittsburgh, Freiburg in Germany, and Harvard. So we use 6 academic centers, 2 continents, USA and Europe, differences in clinical practice, different gene expression profiling technologies. We use something called encounter analysis system, microarrays. We use different compartments of PVMC, peripheral blood mononuclear cells, and whole blood, and we actually study different outcomes. But the reproducibility of our findings were pretty impressive despite all these differences. So this is just to summarize something that we use called SAMS, or the scoring algorithm of molecular subphenotypes. So I had a problem when I first looked at this heat map because to me it didn't look perfect. So again, this was created by artificial intelligence. There was some purple, but there was some yellow here. There was some purple on the other side. It just didn't look pretty. So I tried to come up with a better way to do this, and this reminds me of what I was like when I tried to mix artificial intelligence with human intelligence, and I want to just play this video really quick. It's funny, the face of this animal reminds me of the face of Dr. Restrepo when I tell him I have IDS. He's like, what are you talking about? Anyways, so let's move on to the next slide. Scoring algorithm of molecular subphenotypes. So bear with me. It's a little hard to understand, but it works. So we calculate 2 scores, one score called the up score and another score called the down score. And it's calculated based on the product of 2 variables, the number of up or down regulated genes and their expression level. And we can identify risk profiles based on the score. So you take this heat map, right, where every column is a patient and every row is a gene, and then you turn it to the side, right? So, and then you split it into 2. So the up score is based on the genes that are increased. In this case, we're 7 genes, and the down score is based on the expression of these 45 genes that are decreased. So you essentially determine the number of genes that are either increased or decreased. In this case, let's say 5 out of 7, that's 71.4%. And then you also calculate the mean expression level of each gene, and then you multiply 1 by 2, and it gives you something called the app score. There's no R code. We can do it in Excel. And then you do the same for the down score. So essentially what you get is a weighted average of the gene. So when you plot the scores on the y-axis and then on the x-axis, you get the cohorts. You see that there's patients where the scores are flat, right? So essentially, there's no change in gene expression, but you get these patients with high up scores and low down scores. So remember, yellow is up, purple is down. So we classified a high risk profile if a patient had an up score above the median and a down score below the median. And this is how it looks like. So, so for Yale University, you can see that the patients in the high risk profile have predominantly increased expression of the 7 genes and decreased expression of these 45 genes. And these patients in the high risk group had lower survival. This was in London cohort, exactly the same profile with the decreased survival. This was University of Chicago, same exact presentation. High risk was associated with decreased survival in IPF. University of Pittsburgh was the same, and Freiburg University in Germany was the same. We also studied Harvard University, Brigham and Women's Hospital. They had the same profile, and all these Kaplan-Meier's were significant. So this is how it looks like. So we have patients in the low risk groups, so where they have purple on top, so that means decreased expression of the 7 genes, and yellow, which means high expression of this genes that represent, T cell signatures, and in the high risk subpopulation, which is the opposite. And, because we have more patients, we can actually study the clinical characteristics of these patients. And what we notice is the high risk patients were mostly males with lower values of lung function tests at presentation. So they had lower FVC, DLCO, FEV1. And we actually use a clinical prognosticator called the GAP index, stands for gender, age, and physiology. The GAP index in these patients were a little bit higher, actually significantly higher. So just to summarize the slide, the patients with high-risk genomic profiles were predominantly males with worse physiological and clinical markers of disease severity at presentation. And, when we look at outcome differences, patients in the high-risk profile had increased mortality and lower transplant-free survival, and this was adjusted to clinical variables. Some of these patients were taking immunosuppressive therapy, so people say, well, you're giving them immunosuppression, so you're killing them more, but we did the analysis excluding the patient without taking immunosuppressions, and the results were the same. So there was no confounding effect. Actually, I had a really hard time publishing this paper. It probably got rejected like 7 times, and finally got into a science journal because they got tired of me with all the reviews. I always answered them back, but you got to be resilient if you ever want to publish. And then we did the same exercise when you combine genomic information. So we used the GAP index, the one I just mentioned, with a clinical information. So genomics GGAP. So the GGAP index increased prediction of mortality with an AUC of close to 80%. So we could predict 80% of the patients that would die within 90 days, combining clinical data with genomic information. So the next question is, do patients shift their genomic risk profile over time? So we took a cohort of patients at the University of Pittsburgh. It was like 120 of them, and we followed them over time for over 6 years. This is how long I've been studying this disease. So we would take the blood of these patients every 6 months, and we measure the 52 gene signature for these patients, calculated SAM scores, and plotted the differences over time. And you can see the low-risk patients, the scores are flat. And we see this in clinic. There are patients with IPF that they're just stable. They don't progress. But we have these patients where they actually have significant changes of their lung function. So for example, in the up score, so these are the genes that go up. In the high-risk patients, the gene kind of went up, stabilized a little bit, and then went up again. And we saw the opposite with the down scores, which makes sense. The genes go down, stabilize, and they go down. So we actually ask ourselves, well, what happened during these fluctuations in the expression of these genes? And, so I call this bidirectional changes in scores. So when the up score goes up and when the down score goes down, actually the patients die more. So if you have a more than 10% bidirectional change in SAM scores, the patients will die within 90 days. So that was pretty impressive, I think. So, I was practicing pulmonary critical care in Naples, and I got a call from Madeline Scott, and she said, hey, by the way, I think that I know where your genes are coming from. And I said, yeah, where? And so she goes, I think they're coming from monocytes. Some of your genes, the genes that are increased. I said, why? Well, she did something called cellular deconvolution. So what she did is she took the microarray gene expression data, and using artificial intelligence or machine learning, the computer predicted that some of these genes were present in monocytes. So this is on the y-axis, transplant-free survival. On the x-axis is time in years. And what she saw was that patients with increased monocyte counts, based on the microarray expression study that I did, had worse survival compared to patients with low monocyte counts. And this was in Pittsburgh and Chicago cohort, and we validated this finding in another cohort called the COMET cohort of patients evaluated at the University of Michigan in collaboration with Fernando Martinez. And then, I had monocyte counts on one of the cohorts that I studied, the Yale cohort, and what we found is patients in the high risk subgroup had higher monocyte counts compared to the patient in the low risk group. So that that went to my next questions. Are 52 gene risk profiles exclusive of IPF, or can they be seen in other diseases that can cause lung fibrosis? And this was actually the idea of Brenda Juan, who was a faculty in our division. This is a picture of us at the Oven Center. So Carol Perot, Bosra Turkey, Elisa Arsenal, Brenda Juan, and myself. And this was work that we did here during the COVID-19 pandemic. So as you all know, SARS enters the alveolar epithelium and affects alveolar epithelial cells. And as I told you previously, IPF is thought to be caused by repeated cycles of alveolar epithelial cell injury. But it happens chronically. In SARS, it happens acutely. So the virus affects the alveolar epithelial cells, and that leads to recruitment of neutrophils and monocytes, right? So remember the monocyte/macrophage activation syndrome in COVID-19, which, you know, those monocytes release a lot of interleukins, IL-1, IL-6, TNF. That leads to capillary leak, ARDS, and some patients develop lung fibrosis. So as you can see, this is a picture of a patient post-COVID-19, and you can start seeing some peripheral-based reticulation, especially at the bases. Does it look like IPF? Not necessarily, but they did have lung fibrosis. So we asked ourselves, boy, can we identify risk profiles in COVID-19 based on the same genes? So this was work by Brenda. And we decided to change the colors because we didn't want people to get confused. So in these heat maps, every column is a patient and every row is a gene, and red, it's increased expression of the genes, and green is decreased expression of the genes. And we actually had 2 cohorts. We always like to validate our findings in multiple cohorts. So we use a discovery cohort from patients from Korea, and we use a validation cohort of patients from Buffalo University. This was in collaboration with Ariel Jaitovich. And what we discovered is that, you know, for example, for this small cohort, S stands for severe, M stands for mild. Patients with the high-risk profile, calculated by SAMS, had severe disease, all of them, except with 1 patient in the low-risk group. And if you actually see, this patient looks more like a high-risk patient. It's just SAM didn't classify it, and I can't really cheat. So in the validation cohort, the results were exactly the same in these patients. I'm going to show you, this is pretty impressive, how the high-risk profile subgroup compares to the low-risk profile subgroup. So patients in the high-risk subgroup had higher incidence of ICU admissions, 72, almost 73% compared to 17%, higher incidence of mechanical ventilation, 62% versus 12%. Death, only 1 patient in the low-risk group died, 23 patients died in the high-risk group. Ventilator-free days was statistically significant, and also hospital length of stay. These patients also were older, had higher Apache 2 index, Charlson comorbidity scores, and markers of disease severity in COVID-19, higher ferritin, C-reactive protein, albumin, and absolute lymphocyte counts were also lower in these patients. They were also more likely to be treated with steroids and convalescent plasma. So when we did single cell analysis, so what is single cell analysis? We actually, the technology has evolved so much that we actually take 1 cell and analyze the expression of the entire human genome in 1 cell. So, and we actually calculated SAM scores in all the cells of the human genome. And we found that the cells with a high-risk profile were primarily CD14 monocytes, dendritic cells, and neutrophils. And the cells that have decreased expression of these genes were predominantly T cells. So this is work that has been done by Elisa Arsenal and Bosra Turkey in our lab. So we actually validated these findings at University of South Florida in a cohort of patients collected at Tampa General Hospital. This was during the Delta wave, and we can see in panel B in the high-risk subgroup, again, validates our findings. These patients die more. And we actually trended the SAM scores of these patients during the hospitalization. So this is the up score at day 2, so 48 hours after admission, and look how it goes up at day 6. This is the down score at day 2. It goes down at day 6. So these genes increase during hospitalization, and these genes continue to decrease during hospitalization. And again, the difference between IPF and COVID-19 is COVID-19 was very acute, IPF is chronic. We actually took some of these patients in the clinic when they presented with post-COVID pulmonary fibrosis because we wanted to understand whether the signature was a marker of injury or fibrosis. And this gene actually, they went down during post-COVID pulmonary fibrosis. So that indicates that the 50, in this case is 50 because we had to remove 2 genes because they were not present in the new generation of arrays, are a marker of alveolar epithelial cell injury that leads to fibrosis. And we also measured the cytokine profile of these high-risk patients and found that patients in the high-risk subgroup had high IL-6, IL-10, IP-10, and other profibrotic cytokines such as SPP1 and transforming growth factor beta, which is the master regulator of lung fibrosis. And we also recently did a single-cell analysis of patients with acute COVID-19 and confirmed that patients with the 7 genes, PLBD1, TPST1, MCMP1, IL-1 receptor 2, HP, FLT3, and S100A12 are present in 3 types of cells that have a origin in the bone marrow, classical monocytes, intermediate monocytes, and myeloid dendritic cells. So we believe these are the cells that give the source of this high risk profile, and these cells are bad. So I want to switch gears for the last part of my talk and talk about mast cell expressed membrane protein 1 and the role of this gene in pulmonary fibrosis pathogenesis. So mast cell expressed membrane protein 1 is here. It's increased in the high-risk subgroup of IPF patients in COVID-19. And why did I get interested in this gene? And it's very simple. If you type MCMP1 in PubMed, there's only 22 publications since it was first described in 2005. Whereas if you type in troponin, it's been reported almost 35,000 times. So I thought that, this is very novel, and I don't want to study something that's boring. So in collaboration with my mentor, Naftali Kaminsky, and collaborator, he actually did single cell analysis of cell suspensions from lung lysates. So, and these are called TSNE clusters. So he studied controls, COPD patients, and patients with IPF. And so each cluster determines a cell subpopulation. So this, for example, are macrophages, monocytes, T cells, etc. And when we study MCMP1, this is the color scale. So when it gets to green to yellow, that means the expression of the genes is increased. So MCMP1 is increased in alveolar macrophages and also in monocytes. So we can confirm this in panel D. And when we compare the controls, MCMP1 expression is much higher and significantly different in IPF compared to controls in alveolar macrophages and in classical monocytes. And as you all know, monocytes differentiate into macrophages. So this work by Carol Perot in our lab, she actually looked at the expression by immunofluorescence of MCMP1 in normal lungs, and as you can see, it's completely absent. So red is HT280, which is a marker of alveolar epithelium, right? So this is the alveoli, and there is no MCMP1 anywhere. So MCMP1 is in green. And in IPF patients, you can actually see these clusters of alveolar macrophages that express MCMP1. It's pretty cool in these images. You can actually see in green. So this picture confirms that MCMP1 is primarily expressed in alveolar macrophages in IPF. So we wanted to, see what, MCMP1 responded to. So we took THP1 cell lines, which are monocyte cell lines, and stimulated these lines with all kinds of stimuli, but they only responded to TGF-beta, which is the master regulator of fibrosis. And this was confirmed. This is MCMP1 expression level by PCR, and this is protein level by Western. So we can see that TGF-beta increases MCMP1 protein levels, and also in a dose response manner, right? So as you can see here in panel B, MCMP1 expression increases with different concentrations of TGF-beta 2, 5, and 10 nanograms per ml in over 12 hours. And this is a graph that shows how cells start expressing MCMP1 when they get stimulated with TGF-beta. So to try to continue to study the mechanisms, we say, okay, well, what happens when you give TGF-beta to this THP1 cell lines, monocyte cell lines, and MCMP1? So they don't necessarily have any changes in proliferation, but they do have a significant change in monocyte chemotaxis. So we use this chambers or a transwell, but we put monocytes here and we add CCL2, which is a chemoattractant, and treat the cells with TGF-beta with and without MCMP1 level. And the way we do this is we knock down MCMP1 by using something called a silencing RNA, or we use an shRNA to overexpress MCMP1. So in this graph here, for example, we see that when MCMP1 is knocked down, the cells migrate less, and when you overexpress MCMP1, the cells migrate more. So, Carol, actually, we did this. We asked the Jackson lab to help us generate a MCMP1 knockout mice. So this mice, using CRISPR-Cas, essentially, they're born without the expression of this gene. We completed this project not too long ago. Finally got the N1 mice. So the N1 is the first generation of the mice with no expression of this gene. And but you have to cross the mice for multiple generations because you want to have a pure MCMP1 knockout mice. But we were kind of in a rush because I was trying to submit an R1 and we took a heterozygote. So the heterozygote mice has one copy of the gene, and we give this mice bleo. So this graph is for example, the changing way. So bleomycin is an agent that can induce lung fibrosis in animals, right? So we compare the MCMP1 heterozygote, which is this mice over here, with a wild type mice, which is a mice that has no mutation of the gene, and we gave this mice bleo. So the mice that had less MCMP1 was actually able to survive during the entire experiment. It did lose some weight, but it survived. Whereas the mouse, I'm sorry, with bleo, died at day 7. So MCMP1 seems to be necessary for pulmonary fibrosis in vivo, and the lack of this gene confers protection. That's preliminary data. We are in the process of doing the experiments right now, and this was confirmed by measuring collagen 1 expression. So you can see that wild-type mice had a lot more collagen compared to the MCMP1 heterozygote, and this was statistically significant at RNA and protein level. And, I want to end my talk by work done by someone else, because, I don't want to be the only one. It's kind of tricky when you're the only one talking about the same thing. So Ms. Sharon and colleagues, they discovered something really similar that leads to my overarching hypothesis. So what they did is they treat mice with bleo and flu, and they actually tracked monocytes during the course of the disease. And they noticed that this monocytes transition to interstitial macrophages and then to alveolar macrophages. So monocytes are in red, resident macrophages are in blue. And what they demonstrate is over time, this monocytes get into the lungs and transition into alveolar macrophages, and they persist over time. So their hypothesis is that they call this TRAMs, or tissue resident alveolar macrophages, and they call this macrophages MOAMs, monocyte-derived alveolar macrophages. That are, they essentially come from the peripheral blood, and they participate in fibrosis. So our hypothesis is that high-risk gene expression profiles based on the 52 gene signature represent activation of monocyte-derived alveolar, represent activation of monocyte-derived alveolar macrophages, or MOAMs, during alveolar epithelial cell injury that lead to aberrant wound repair and lung fibrosis. Those monocytes are MCMP1 positive, and blocking MCMP1 will lead to decreased monocyte chemotaxis during injury, decrease fibrosis, and improve survival. So that's our hypothesis, and that's what we're going to be working in the next few years at the Oven Center for Pulmonary Fibrosis Research. We hope that by blocking MCMP1, we can actually stop the cells from causing harm, injury, and fibrosis. So in summary, IPF has a variable course and is associated with high mortality. A 52 gene signature accurately distinguishes a high risk profile associated with increased IPF mortality. 50 genes of the 52 gene signature are also predictive of COVID-19 mortality. Increased expression of 7 genes of the high risk profile can be seen in classical monocytes and alveolar macrophages in IPF and in COVID-19. And future strategies to neutralize MCMP1 could lead to treatments that could improve IPF survival and the survival of patients with other fibrotic lung diseases. Some experiments we're trying to do is we're trying to identify whether MOAMs or monocyte-derived alveolar macrophages express MCMP1 in IPF. I was talking to my lab members this morning about that. We also want to determine, finally, whether MCMP1 knockout mice are protected against bleomycin and adeno TGF-beta-induced lung fibrosis models. We want to also determine whether MCMP1 knockout mice are protected against influenza and COVID-19 induced acute lung injury in ARDS. We want to characterize the structure of the MCMP1 protein because there's nothing known about this protein and elucidate its function and mechanism. And we want to develop a drug that targets this gene and protein. I want to finish my talk by thanking Timothy and Sharon Oven. I don't know if you guys know who Mr. Timothy Oven was. So Tim Oven was a patient of mine and actually my friend. He died about a year and a half ago with after an acute exacerbation with pulmonary fibrosis. When I told Tim, he was my patient in Naples, when I told him that I was going to move to University of South Florida, I said, I want to go back to science, but I don't have any money. And he said, how much money do you need? And I said, can you give me $1 million? And he said, sure. So he wrote me a check, and just a couple of days after I arrived to USF, I opened up my lab. And Thanksgiving's last year, a week before he died, he gave me $5 million to build the Oven Center for Pulmonary Fibrosis Research. So I'm in great debt to him. And I promised him I was going to come up with a treatment for pulmonary fibrosis. I want to acknowledge my collaborators and my research mentor, Naftali Kaminsky, Ian Noth, Ivan Rosas, Erica Herzog. Remember, this is the work of many years and many patients, and all of those PIs recruited these patients and collaborated to discover the science that we hope we can move the field forward. I also want to thank the Harold Amos Faculty Development Award and the Pulmonary Fibrosis Foundation. They gave me money to do research. To Gitat Michaud, because she believed in me and my research. She brought me back. And Steve Liggett, he gave me a lab and an office right next to him. I think he was worried I wasn't maybe going to do so well, but I think I'm hoping I'm making him proud. John Synod and Mark Mosley for their trust in helping me leading this division, and obviously Charlie Lockwood for all his support and help. Thank you. I'm ready to take any questions. I can see a question from Abdullah.
Yeah, I was wondering about the 52 gene profile and how did it come to the choice of those specific genes that led you into studying them and the expression of those genes? What led you into targeting those specific genes?
Yeah, so that was so what you do, Abdullah, is when you have 30,000 genes and you have the survival information of the patients, you do a Cox proportional, univariate Cox proportional hazard models. So you ask the computer to help you identify genes that are predictive of the survival outcome that you're looking for. So I didn't pick them. Essentially, the Cox proportional model came up with those genes. So it's an unbiased approach. Does that answer your question?
Yes, thank you.
Dwight?
Thanks, Jose. That was really interesting. So I've got a couple of questions. Apologies. The first one is just to make sure I understood. So the genes that you're looking at the transcriptome. So you're looking at the genes that are actually being activated or not activated, and the patients that have activated versus non-activated genes could actually have the same genotype. So you're not looking at like SNP differences or anything like that. You're just looking at genes that are being turned on versus off, and the patients could have the actual same genetic background. Is that right?
Correct. Yes, this is a very important point, and Dwight, and thank you for bringing that up, because I should have clarified. So there's differences in genetics and genomics. Genetics look at variations in the genome. So instead of having one letter A, you have another letter T. I'm not studying genetics. I'm studying genomics. Genomics is the science of the expression of a gene. And the genes across patients will be the same, but the expression of the gene is different because, like you said, the gene gets turned on or off by certain stimuli. In the case of the 52 gene signature in the high risk profile, it gets turned on by alveolar epithelial cell injury. Does that make sense?
Yeah, thank you. And so then the second question is, so you're looking at the transcriptome specifically, your original studies were in PBMCs. And so does that limit you to looking specific, or I shouldn't say limit, but basically you're directing your view specifically at the immune system, as opposed to say like genes that are being activated or not activated in fibroblasts in the lungs. Is that right?
Right, yes. So another important point. So I wanted to look at immune cells, and it's interesting. In the past, or when I was a resident and then a fellow, people changed the perception of IPF as an immune-driven disease, because when they treated patients with immunosuppression, the patients die more. So it said, forget about it. There's no role of the immune system, and that's what I had such a trouble publishing my first paper, because I had to change the concept that IPF was indeed driven by the immune system, but a different arm, which are monocytes, not T cells, right? So, and there's been an explosion of publications regarding the role of monocytes, monocyte-derived alveolar macrophages, and macrophages in the role of pulmonary fibrosis, thanks to this research. So yes, if I have to look at cells, I look at cells in the lung, I look at macrophages. Remember that macrophages interact with fibroblasts. Matter of fact, the number of fibroblasts determines your macrophage population. So macrophages activate fibroblasts, and then the fibroblasts grow. So it's just looking at a different arm of the disease. Any other questions?
Yeah, really interesting. Sorry, last one is, so the overall hypothesis is that this is overall driven by alveolar injury and then failure to appropriately regenerate. IPF is a very peripheral basilar disease. Do you have any thoughts about why you see that phenotype? Do you think it's just the mechanics that happen in the periphery and the bases of the lung, or is there some other reason?
Yeah. So that's an interesting point. We will probably need to look at whether, let's say, monocytes tend to have a preference for the bases of the lungs. So that's something that we could look in the future.
Dr. Guerra has a question in chat. Are there gender or ethnic differences in how IPF manifests itself in patients?
Yeah, so it's predominant. More predominant in males than in females, and more predominant in white males, actually. So it tends to affect white males.
I had a question, Jose. With this, it seems to me the common thread being the self-sustaining fibrosis with progressive decline. What for you is the best? We have a lot of indirect markers. Is there a direct or any genomic correlation with the phenotype of chronic or progressive disease, or a simple way to sort them out?
Yeah, so John, think about it this way. The orchestrator is the alveolar epithelial cell. So when this cell gets injured, that triggers the activation of the monocytes and these genes, and then the transition of the monocyte to the alveolar macrophage. If the injury happens persistently over time, that leads to more scar formation. In the setting of COVID-19, for example, the injury happens acutely, creates scar and regeneration. But think about it, if someone would suffer Delta 5 times, right? The amount of fibrosis would always, it will be worse because it's orchestrated by the injury to the epithelium. And what we're looking at here is how the cells migrate and cause aberrant repair. I see someone ask, Arslan?
Hi, Dr. Rose. Thank you so much for a wonderful talk. It was really eye-opener. So my question is in regards to the activated monocytes leading to macrophages and its commercial implication and the timeline for that. So from a commercial point of view, when will it
Sure,
be, you
yes.
think?
So I'm, this is the way I see it. Do you know Nucala, right? So Nucala is a monoclonal antibody against eosinophils. So I'm hoping that we can develop monoclonal antibody against MCMP1 positive monocytes, and treating those cells will actually change the treatment of fibrosis. The timeline, I can't really tell you. It's, you know, science takes time. So what we're doing now is we're trying to purify the MCMP1 protein. We're trying to identify the cells, creating maybe a monoclonal antibody against MCMP1 or any other of the markers of this monocyte-derived alveolar macrophages, and get it into clinical trials. It could take 5 years, 10 years. I don't know, but that's what I'm here for.
Got it. Thank you. One more question, which is not entirely in regards to your research, but as an expert at the IPF, I just want it's kind of a thought process. So you mentioned about nintedanib and pirfenidone and antifibrotic activity, and we all know that scar tissue is the nidus for the cancer. Is there a role, current or future, for these medications and chemoprophylaxis of the lung cancer? If you know.
I don't think there's any research in the area, and I doubt they will work in that regard. They affect, you know, the proliferation of fibroblast. Supposedly they have anti-tumor activity, but that's something that we probably could look at, right? You know, whether patients taking nintedanib or pirfenidone have less incidence of lung cancer. That's something that a project that you and I could do. Happy to help you with that. I see other questions here. Carlos.
Hi, Jose. Thanks. I have a question that is sort of the opposite that you publish. Have you come up any transcriptomes that actually have a better prognosis for IPF patients, and then some of those proteins could be also targeted in the future, or genes, excuse me?
Yeah, so that's a very interesting question. So remember that we studied these 52 genes. So the transcriptomic profile that associated with improved survival is the low risk. So the high risk predicts worse survival. The low risk predicts better survival. So if those 7 genes are turned off and the 45 genes are turned on, that means that you will do better, right? So essentially, so the same 52 genes gives you 2 profiles, a good profile and a bad profile. And it depends on the direction of those genes. I have not come across any others. These are the only ones I've studied so far.
Gotcha. Thank you.
Any other questions?
Hi, Dr. Herazo, it's Evan. I was just curious to know what your perspective is on the phosphodiesterase 4B inhibitor that's being investigated and how it might play a role in the treatment for IPF.
Well, I think it's a great drug, and I think that the preliminary findings are pretty promising. It seems to slow the progression of the disease, and you know, hopefully the phase 3 will show that it works. And you know, pretty soon we're going to have a third drug in the armamentarium to treat IPF. Now, the issue I'm having with most of these drugs is that they slow the progression of the disease, but they do not change survival. So the reason why I study genes that are associated with survival is my hope is that when you block some of these genes, you're actually going to have a survival effect, right? I don't want just to slow the progression of the disease. I want to save lives. So if you show me that there's a drug out there that actually increased survival, then I think that's the cure of pulmonary fibrosis. But you know, hopefully, you know, we'll get there, but we're not there yet.
Thank you.
All right. Thank you, everyone. This was great.
Thank you very much for a superb presentation.